If you want all of your data in one place, you need the Intuit ERP. I'm Damon John, and I run my growing business on Intuit Enterprise Suite. Learn more at intuit.com/ERP.
And we're live from the living room as Doug eyes up the match day spread. He's reaching for the buffalo wing. Perfect! Hang on, what's this? Oh, he's gone for a can of Pepsi too! Incredible! What a finish! Sensational combination! Look at the delight on his face. There's no doubt about it. It just tastes better. Match days deserve Pepsi. Food deserves Pepsi. Grab a pack of Pepsi Zero Sugar for today's match. It's poetry in motion.
This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
And I'm Dr. Sonya Tredici.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. The podcast offers Category 1 CME credit through MyCares and Michigan State University. The links for the CME are in the show notes. This week, we're going to be discussing a new protocol for direct-to-inject buprenorphine. Sonya, how are you tonight?
I'm doing amazing. How are you?
Living the dream. By the way, I was a little hurt that you didn't come to the addiction medicine department baseball game on Sunday. I forgot to give you a hard time about this. You didn't come, and I felt like totally like where my partner in crime was.
Oh, was it fun?
Yeah, it was really good.
Next year, it's like an hour drive. It's my day off. I stayed home and worked in the garden. I had mulch to spread.
It was really nice.
Yeah, it's so fun. I also didn't go to the addiction medicine 5K this year. Did you run that?
I had another thing with my kids' sporting event. Although I love that 5K because I'm a runner and I'm a mediocre runner, but I feel like I'm juicing at that run because everyone's smoking right before the 5K, and so you can have a 24-minute 5K and you're like in the top 3.
Yeah, that's a fun time. I'm hoping, my youngest child is leaving the nest. And so next year I'm not going to have anything to do on the weekends. So no sporting events, no nothing. So maybe I'll be able to go to all these things next year.
Yeah.
All right. So, hey, I wanted to share some good news with our listeners. I thought this is something people would be really interested in. It's not really good news. It's a good news source. It's something called KFF. It's an independent news site. And if you feel overwhelmed with trying to track all the things that are going on politically or with healthcare policy, because things are constantly in flux, but without the drama or the kind of catastrophizing, I want to recommend this site. They have a tracker of the current political administration's key policy actions related to substance use disorder and other areas if you're interested. John, if you want your blood pressure to go up, definitely look at it. It'll just, it says in very neutral language, these are the key administrative initiatives. And I'll put a link in the show notes. But so do you want to hear the key administrative health, substance use disorder initiatives for the last 2 months?
Sure.
You ready? Feeling relaxed?
No.
Okay. Number 1, advising on the harmful effects of screens for children. That's good. Increasing sales of fruit-flavored vapes.
Okay.
Addressing drug crisis by focusing on border control and drug interdiction, removing federal funding for harm reduction services like drug checking strips, reducing psychiatric medication prescribing, using SAMHSA funds to train providers to reduce and taper medications for opioid use disorder, reclassifying cannabis, increasing the use of psychedelics, and massively cutting funding for all of the agencies that work on mental health and substance use disorder. So those are the policies currently being, worked on.
Yeah.
The only one I really like is addressing harmful effects of screen use on children.
You know what? I was kind of excited. I felt kind of optimistic, and then it just kind of trailed from there for me, inside. And then it became from excitement with the screen time to disappointment to I was kind of getting anger at the end of that.
What do you think about increasing the sales of fruit flavored vapes?
It is interesting. That's I don't know. I just don't understand. And you got the head of HHS vaping at congressional hearings, and that's that's one of their key priorities is fast tracking nicotine pouches and nicotine vape products because that's truly an HHS crisis.
They left off any mention of beef tallow, though. John.
It's coming. You can tell our audience because it's like we don't get any negative shit when we say stuff like this.
If anyone,
The one that does have me concerned though is that all this. Many of these are concerning. This deep prescribing of SSRIs, I feel like it's like vilifying something that's very helpful. We have a mental health crisis in this country, and we're going to start by removing medications that are like life saving and actually are not habit forming, and they don't cause harm. In fact, there's tons of. I saw a very interesting study about fMRI data for patients with depression treated with SSRIs. They had higher brain volume and better fMRI activity as they aged. Sort of like a kind of a time is brain phenomenon with SSRs for treatment of depression and anxiety. So they're definitely like life and brain saving. It's just crazy that we're vilifying these. This is going to be more harm, right? All of our things that are helping people, we're vilifying off of like some BS pseudoscience.
The thing that really worries me is training all providers to reduce and taper off medications for opioid use disorder, and by that they pretty much mean buprenorphine. So like there's even talk about like having mandatorily documented conversations once a year about when is the patient going to taper and do they want to taper, and that just goes against all science. And I worry that they're going to reverse the gains that we made in the last few years on reducing opioid overdose. We've done all these things and overdose deaths have finally gone down, and now we're kind of canceling those things again.
Yeah, although I'm going to play devil's advocate here. How many times have you gotten a patient from another clinic where they paid their $50, they left their urine sample, they got their medication, and 3 years in, you're seeing them for the first time, and no one's even asked them what their long-term plans are for recovery. There should be a discussion about it shouldn't be this kind of fee for service. Like that feels very pill-milly, right?
Yeah, if you never discuss what's the future gonna hold. Totally. Yeah. But those are just like bad doctors. They don't discuss anything,
Yeah, but that subgroup again, they're typically high volume like shops, right? So it's like you're right. It's a couple one-offs that are high volume.
My policy is, because we do a controlled substance agreement once a year. So every time I see that controlled substance agreement on the desk, that's a sign from the nurses it's been another year with the patient. And actually, I do address tapering. I don't encourage tapering, but I say, hey, it's been another year. Are you happy with where we are? You think you might want to come off it? Do we want to make any changes? So I do. Actually, maybe I'm like in lockstep here with the administration on that one once a year. But I don't tell patients that it would be better to taper.
Yeah, I use kind of more neutral language. I'm like, so what's your plans this year with your recovery and the medication?
Right.
It's potato.
Oh, all right.
I got an article today because I actually did some homework.
What do you got?
It's from CBS News. I thought it's very interesting. It's called The New White House Drug Abuse Strategy Floats Wastewater Testing AI, More Treatment and Faith-Based Options. Did you see this on CBS? This is a lay article.
No, but it sounds like it's kind of on theme with what I said. So you and I are like in lockstep here.
Yeah, it's interesting. They're talking about they have the Trump administration proposed the 2026 National Drug Control Strategy. It's a 195-page federal plan. It's a lot of paperwork about like basically drug treatment addiction, expansion, aggressive surveillance, and then kind of like integrating technology into drug monitoring. It's interesting because like a commentary that started the article is that we're going to introduce a new strategy in the wake of declining drug deaths since 2023. So, it's kind of like we're actually like doing a really good job to kind of step in and say we're going to change course. So, a couple of the major points that they pulled out that I thought were interesting. One is actually, the first one's kind of interesting about basically using wastewater surveillance. So wastewater surveillance for kind of local drug metabolites and basically drug contaminants. So kind of seeing what the drug supply is in real time. I'm actually not that opposed to that. That actually sounds kind of relatively interesting. There's own ethical issues there, but some sort of data-driven way to understand how the drug supply is evolving in front of us for us to respond would be interesting. You can't go to any meeting at this point without someone floating the idea of adding an AI for something. So, of course, AI was part of it. We talked about using AI to analyze cargo ships for basically to flag ones that could be from illicit drug ports or possible locations, or that have kind of cargo that could be suspicious for searching. Identifying patients at elevated overdose risks through the EMR. So kind of trolling through our EMRs for risk. Detecting emerging synthetic drug use among algorithm monitoring, so kind of combining with that wastewater treatment. They love their expanded treatment access. They really love these faith-based recovery programs, which are many patients do find them very helpful. They love that in these farms, right? So everyone's going to be working on a farm and recovering that way.
Everyone's already working on a farm where we are. That's what you do.
I also
around
love they
here.
have to say that they want to focus on new prevention messaging. So they think that American culture has become increasingly permissive towards drug use. So they really want to kind of start a youth campaign for substance use. So I guess DARE is back.
I think you should let AI monitor the wastewater. The wastewater monitoring is like the world's most giant urine drug screen, and AI should be able to like pick it apart and tell us what's going on.
Yeah, so I think, they kind of talk about pros and cons. I think it's interesting that, like a real-time surveillance, like the wastewater monitoring could be useful for kind of understanding the evolving drug supply. The AI tools certainly can be predictors. I have less heartburn using it to kind of evaluate ship cargo containers for, suspicious cargoes or ports than I do for combing our EMRs. I feel like, I already think that a lot of patients with substance use issues feel that the EMR is a weapon against them, right? So I think that I don't want to put any more barriers between them coming to see us. I mean, I like the idea of expanding treatment infrastructure. I think, people recover different ways. So I'm sure some people really would respond to faith-based recovery programs and drug farms, but I still think that we have a lot of other...
Don't call them drug farms.
What's it called? Wellness farms?
Wellness farms. Recovery farms.
Recovery farms.
I don't know what they're called.
I mean, that might be appealing to some patients, but I think that the idea that we're going to... that should be in addition to what's existing already, right?
Right.
I think that people do worry about kind of like infringing on people's civil liberties with kind of like monitoring the wastewater, coming through the EMR. I think those are all valid points. And then I think it's interesting, the paper did as well talk about that these harm reduction programs are probably not something that they feel add a lot of value. So fentanyl test strips, syringe exchange programs. So I think it's just it's interesting. It's like a shift while you're winning the war.
Right.
While you're, the momentum has changed in the positive, and we're going to go backwards.
I mean, we'll see. The numbers, in terms of overdose deaths are so complicated and so many factors go in. I hope they'll continue to go down, maybe despite everything we do rather than because of what we do.
Sure.
You don't sound convinced.
No, I'm optimistic in some regards.
I mean, it's been a good few years in terms of treating opioid use disorder. Like things have definitely gotten better in the last few years. So I'm optimistic too. Are you?
It's amazing that we have like someone running this though that has like lived experience, and they totally blown this thing up.
Well, I mean, I think that's the problem with lived experience sometimes is people try to extrapolate only from what worked for them to what would work more in general. I remember our recovery support specialists, we both work with the recovery support team, and they told me as part of their training is you have to learn that just because something worked for you doesn't mean it's the best way. And not only is it not the best way for everyone, it might not be the best way in general. You might just have gotten lucky. And that's like a big concept shift for a lot of people. But you'd think our top medical person that wouldn't be such a hard concept. But he feels like what worked for him is the way to go.
Yeah. All right. So tell us about your article. Let's go on to something more positive.
All right. This is very positive. This was like all the rage at ASAM this year, this direct-to-inject buprenorphine. This article was published in the Substance Use and Addiction Journal. It's called Outpatient Initiation of 7-Day Injectable Buprenorphine, a direct-to-inject case series. A little bit of background for our listeners. As we know, fentanyl-involved overdose deaths are common, and buprenorphine is an effective treatment, but it's really only used by about 25% of patients with opioid use disorder, and that's not for lack of access. It's mostly patients not seeking out that care. One barrier of patients seeking out buprenorphine is fear of precipitated withdrawal, which can be severe, and it's observed in between 11 and 16% of patients who are using fentanyl. So that really keeps people away from wanting to start buprenorphine. Now we have these injectable buprenorphine products. They've been available since 2017. Current protocols call for like a 4 milligram sublingual test dose prior to giving the injection. But this test dose, a lot of people say it's like just the right amount to cause precipitated withdrawal, especially in patients using fentanyl, but it's not enough to treat that withdrawal. So that's the dose most guaranteed to give you precipitated withdrawal. And you're supposed to take it prior to doing your long-acting injection. So a direct-to-inject protocol, direct-to-inject means you get your injection without stopping your fentanyl. And not really without stopping your fentanyl, but without doing a test dose. You stop the fentanyl, you wait a few hours, and then you do your injection. And because these injections kind of come on a little bit slowly, especially those weekly long-acting injectable doses, they have a gradual and sustained rise in buprenorphine levels. It peaks in about 24 hours. So you actually get a slow rise over 24 hours, which helps mitigate some of that precipitated withdrawal. And there's a few different products. I prefer not to use brand names here, but, there's weekly products and then there's monthly products. And only one of the brands available comes in a weekly. And the monthly products have a much quicker time to maximum level. So just to use some brand names, Brixadi monthly has about 6 hours to peak. The Brixadi weeklies are more like 24 hours to peak. So just there's a bit of a difference in the weekly versus the monthly. And that's the product that was used in this study. So clinical question, this is a retrospective cohort study examining the initiation of long-acting injectable bup without prior transmucosal doses. They had 141 adult patients who tried to initiate buprenorphine 131 times. These were adults with opioid use disorder, and they were being treated in various San Francisco and Oakland, California safety net clinics. So recently from March 2024 to May 2025. So this is hot data, hot off the presses. You had to have a COWS score of at least 4. So starting a tiny bit of withdrawal, and it was supposed to be about 6 hours after your last use of fentanyl. They excluded people on methadone, excluded people who are already on sublingual buprenorphine. But otherwise, if you wanted to be in this study and try this protocol, you could. So of these patients, the average age was 42, 63% were men, 50% were white, and only 25% had stable housing. So this was the 75% of this group had unstable housing or were unhoused. 79% reported known fentanyl use. A lot of them had used buprenorphine before. 88% had used buprenorphine before. 10% had done a direct-to-inject initiation before. And about 47% were using methamphetamine or had used it very recently. So a very disadvantaged population, a group of people that that really struggle. So that's who was in the study. And again, retrospective cohort study. So patients were asked if they wanted to try this protocol. And if they did, their data was recorded. The intervention was that you got a weekly shot. So you said you wanted a direct-to-inject protocol. You got a weekly shot, either 8, 16, 24, or 32 milligrams. And the provider would choose what the dose was. So the higher doses were more likely to treat existing withdrawal, but the lower doses were more likely to avoid precipitated withdrawal. So if you were already in a lot of withdrawal and you wanted to take a higher dose, you could do that. If you were feeling good and you were worried about precipitated withdrawal, you could take a lower dose. So you got a single injection, and then they gave you adjunct medication. Plus, you could continue to use your own fentanyl if you wanted to after you got the injection. After 24 hours, you came back and you could either get sublingual buprenorphine if you wanted to. You could get another injection, a weekly injection, or you could do a monthly injection. Or if you didn't want any of those, you could schedule an injection in a week. So basically, day 1, injection. Day 2, any kind of buprenorphine you wanted. Weekly injection, monthly injection, sublingual bup, or nothing. And you could continue to use your own fentanyl during this protocol if you needed to treat withdrawal. So that's what they did. The outcomes was treatment retention at 7 days, 30 days, and 90 days. And what was your withdrawal severity in the first 24 hours? Because that would be like the precipitated withdrawal window. And they followed patients for about 90 days. So what do you think of the study setup, John?
It's kind of like a really interesting setup, right?
Yeah, it was really interesting, and I'll talk about strengths and limitations, but it was very much a like, this is what we're doing right now paper.
Hmm.
The protocol was sort of in flux. There was a lot of different options, and they just kind of tried it out and saw what happened. So, in terms of strengths, this is very unique data. It's the first report of 90-day outcomes in a direct to inject protocol. The protocol itself was pretty unique, giving a monthly injection 24 hours after a weekly injection, which was what most patients got. I didn't think funding would cause bias. It's funded by NIDA. This is a very hard to reach population, and they had a variety of clinical settings. So, this really allows for proof of concept in different settings, but there will be site level differences, and that may impact success. And finally, withdrawal, it was interesting. Rather than using a traditional COWS, which is the clinical opioid withdrawal score that we use to monitor or to assess withdrawal, they just scored it on more of a subjective patient experience scale. So I don't know if that's good or bad. It makes it harder to compare this to other studies, but it actually is a little more patient centric. And it's like more, what was your experience with the withdrawal? Because you might have a lot of symptoms, but not even be very bothered by it and count it as mild, even though you have symptoms. Some limitations. This was a retrospective cohort study, not a randomized controlled trial. There's no comparison group. And with that, patients self-selected into the study, and many had prior experience with the protocol and self-selected in. You'd think that would increase the likelihood of success. It wasn't huge. 131 protocols carried out. They had a lot of missing data. About 21% of patients' withdrawal data was missing. And the only outcome was retention in treatment. And I know that that's like a main outcome with buprenorphine treatment, and it's also easier to measure, but there was no outcome about drug use, quality of life. And we often use retention in treatment as a surrogate for patient satisfaction, but of course they're not exactly the same. They also didn't do any urine drug screens to confirm fentanyl use or confirm other drug use. They just did patient report. And then because this really was a descriptive study, they learned things over the course of deploying this protocol and eventually kind of changed it throughout the course of the study. So I said before, you had a lot of choices about what dose you would choose for patients, but eventually they kind of realized that initiating with 16 or 24 milligrams and then 24 hours later getting the monthly injection, that was really the most effective. And most patients ended up getting that kind of combination of medications. So, some strengths and some limitations, but a super interesting protocol. Ready to hear about the results?
Yeah.
So, the biggest result and the most unique result is 90-day retention, and 43% of these patients were still retained in treatment, meaning still coming for buprenorphine at 90 days, which for a mostly unhoused, unstable population, that's great. 43% were in treatment still at 90 days who started with this protocol. If we go back a little shorter, we had 72% came back after the first injection. And of those, 88% chose to get a monthly injection as their second buprenorphine dose. 69% came back at 7 days and 68% at 30 days. So people like this protocol enough to come back for a few additional injections. So I think that's the retention and cure data. It's pretty good. The withdrawal results, this is one I was super interested in. So 37% had no withdrawal. And so this is our deadly fear of precipitated withdrawal, the reason for all of these super complicated protocols for starting buprenorphine. And these are patients who are taking high dose opioids and getting an injectable buprenorphine. 37% no withdrawal at all. 31% mild or moderate withdrawal. 11% had severe withdrawal with their injection. But of those, 80% returned for a subsequent injection. So it didn't turn them off the process, even though they had severe withdrawal. And then, of course, a lot of missing data. 21% had missing data. So even if you assumed all those people had severe withdrawal, it would still be less than people who had no withdrawal at all. And then, they looked at a bunch of different subgroups. So how long it had been since your last opioid use, what was your initial weekly injection dose, what was the COWS score, there was no difference in terms of 90-day retention in any of those groups based on how things went kind of at the initial injection. So it didn't really seem to make a difference how you started it or how people felt at the beginning. So what will I do with these results? The direct-to-inject buprenorphine initiation, it demonstrated favorable tolerability, good retention in a high-risk population in a variety of settings. So I really think it's a viable pathway to long-acting buprenorphine treatment for individuals using fentanyl who may not tolerate traditional initiation methods, who may not be able to do that sublingual dose, who find the kind of micro-induction where you take a small dose, slightly increasing every day, sublingual, too complicated. In my current practice, there's some administrative barriers to ordering the medicine, but in a bigger site, especially if they could do buy and bill and with the ability to see patients every day, this protocol would be feasible. So what do you think, John? Would you use something like this in your practice?
I think it'd be tough to logistically do this in my practice, although I like the idea of it. I could see this definitely kind of being like something used in like a public health sector, like, a local health department where you could have like a mobile clinic or go out to patients, and this would be an option. I think it'd just be hard for me. I can't even get buy and bill yet at, in my office. I feel like I've tried so hard. It's just, there's so many barriers.
Well, there's having the medication on hand, and then there's like, what if you're not there 2 days in a row, or the patient doesn't come back on day 2 but wants to come back on day 3? I don't know about you, but I'm in like different places on different days, and like other people in my office won't do these long-acting injectables. So if the patient decides they do want to come in and I'm not there, they can't get the shot. So logistically, it's a little hard.
I think it continues to challenge, though, the idea of this oral lead-in really adding a ton of value. I think that's kind of the big thing I think we're taking away here.
Yeah, agreed.
Yeah, very interesting. I mean, I'm sure there's going to be a lot more of this coming up, right?
I think so. I mean, I think we're just simplifying. We've made it so complicated, and a lot of those complex protocols haven't really proven to be a lot better, especially with the shifting drug supply to fentanyl, than these simpler protocols.
Yeah. Yeah, it's like theory versus reality, right?
Yeah, for sure.
So I really appreciate you presenting that article. I mean, we did get a little bit of talk back, so I want to go over that for a second here. We got a Facebook group comments from Dr. Siri Lankeys. I want to share. It says, I love the podcast. Listening to a recent episode on prescribing and risk of opioid use disorder, I wondered if you've read this paper, which was using a Swedish registry to capture all young Swedish people exposed to an initial prescription to assess how risk of opioid use disorder was affected. It's an extremely powerful approach as they could combine all full national registry. Over 10 years, nearly 1% developed actual opioid use disorder. The paper is titled, quote, Risk Factors for the Development of Opioid Use Disorder After First Prescription, a Swedish National Study. And the main results are interesting. Of people who received a first opioid prescription, 0.9% developed opioid use disorder with a hazard ratio of 7.1. Mean time to onset was 3.41 years, so that's pretty fast. The strongest risk factors for the development of opioid use disorder were prior psychiatric and substance use disorders, criminal behavior, parental divorce, poor school performance, current community deprivation, divorce, and male sex. They developed a risk score that seems better than the EPIC risk score we discussed in episode 77, although it uses risk factors that are not easily captured in our American EMR. We'll put a link in the show note. It's kind of an interesting talk back.
Well, it was so interesting because we talked in episode, like you said, episode 77 about this EPIC risk score that uses who knows what because it's a black box. But I'm sure it doesn't include school performance, parental divorce, parental death, current marital status, all these things that actually are risk factors and lead to the development of a more accurate risk score. They're just not available in the EMR in a structured way, at least our EMR. So this was kind of cool, even though what the main point was about the development of opioid use disorder after a first prescription, which is high even now.
Yeah, I mean, I don't know. I think it's interesting because I think we love our EMR. We love our smart sets and EPIC tools and EMR tools. But, someone talking about a lot of these are very sensitive topics, right? These are not things that people are just going to enter when they check in at the kiosk. They had a divorced parent and they have a history of criminal behavior. I mean, that's a relationship discussions over long periods of time. They'll probably say that they're male, but,
Right.
poor school.
That's about the only one. Yeah.
Poor school performance is so variable. I've learned in my career when I do my well child, you don't do this as an internist, but I always ask so how'd the school year go? And they'll be like, oh, it went well on the go. And I'm like, what does well mean to you? And sometimes straight D's. And I'm like,
Not a single
what?
F.
We might need to work on that together. Well, Yeah, thank you for the talk, Pat. Thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the article included in a future episode, send us your comments on social media, email, or join our Facebook group. The links are in the show notes. Original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support for My Care is produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views here are expressed are our own and do not necessarily reflect those of our employer or the author of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation and having a great day.
Hi, Ryan Reynolds here for Mint Mobile. Are you looking for a beach read this summer? May I suggest your big wireless bill? It's got suspense, mystery, a slightly flat emotional arc, and a shocking twist where you realize you've been overpaying the entire time. Fortunately, though, Mint's story is better. Every plan, $15 a month, even unlimited. That's it. Happy ending, zero tears.
Give it a try at mintmobile.com/switch.
Upfront payment of $45 for 3 months, $90 for 6 months, or $180 for 12-month plan required. $15 per month equivalent. Taxes and fees extra. Initial plan term only. Greater than 50 gigabytes may slow when network is busy. See terms.